I'm delighted to be here and really excited to talk about the paradigm study. First, I'll begin by talking briefly about how do we predict whether or not patients need intensive chemotherapy. And we use a framework much like this one presented by the ELN, where we look at whether or not patients have favorable risk, intermediate risk, or adverse risk based on a number of features, including their cytogenetic and genetic abnormalities. And this then helps us know if patients have a benefit from chemotherapy alone or if they need long-term um, planning for a bone marrow transplant for curative intent. Now, this framework is specific to those patients that require intensive chemotherapy. And so these frameworks were built in order to predict how will patients do if they're receiving non-intensive chemotherapy, such as HMA venetoclax. Here you can see a framework using the presence of TP53 mutations, FLT3, or N or KRAS to help us understand if patients' AML is a unfavorable risk, an intermediate risk, or if none of those mutations are present, a favorable risk, leukemia, for those patients receiving HMA-ven-based therapy. Now, there are a number of other frameworks, including the ones listed here for risk stratification, and at ASH 2025, there's one additional framework that was proposed called PRISM by Kurt Lockowitz and others, using a number of variables, including mutation status, as well as sex, age, and other parameters, including karyotype. This is important, particularly in the context of the fact that we're trying to explore using AZA-VEN regimens for patients that are younger. And this leads us into the discussion of the paradigm study, which was presented by Amar Fathi at ASH 2025, which is a phase 2 randomized multi-center study comparing AZA-VEN to conventional induction chemotherapy for newly diagnosed fit adults with AML. You can see here the inclusion criteria in the bottom right-hand corner: age greater than 18, patients with untreated AML that were eligible for intensive chemotherapy, and these patients were intended to move to transplant for curative intent. The exclusions are in the pink box, mostly include any patient with core binding factor leukemias were not allowed to enroll in the study, any leukemias that harbored FLT3 or NPM1 mutations, as well as BCR-ABL or mixed phenotype leukemias. Patients were randomized in a 1-to-1 fashion to either 7+3 CPX or AZA-VEN-based therapy, and if remission was obtained, continuation with consolidation therapy, and then, of course, moving to transplant. For this patient population, you can see that the primary endpoint was EFS with defined events as listed there, and secondary endpoints included response rates, overall survival, looking at MRD, as well as quality of life metrics. You can see patients were stratified depending on their age, as well as pre-randomization selection to 7 and 3 or CPX in the intensive chemotherapy arm. Importantly, when you look at the baseline patient demographics, they were fairly similar. You can see more patients. However, in the AZA-VEN arm, there were more patients that had harbored leukemias that had IDH mutations. And you can see IDH2 in particular, 22% of the population versus 10% of the population that got intensive chemotherapy. Importantly as well, there were more patients in the intensive chemotherapy arm that had an AML with TP53 mutations, but otherwise they were fairly similar with regard to demographics. When looking at safety, tolerability, and response rates, you can see adverse events here were somewhat higher in our patients with intensive chemotherapy compared to those patients that had AZA-VEN, namely bleeding, as you see in the middle graph. And then 60-day mortality was 0 for AZA-VEN and 4.7% in intensive chemotherapy. When looking at response rates, you can see nice response rates as depicted in the orange bars for reflecting those patients that were on AZA-VEN, with improved overall response rates, as well as CR/CRh, CRi rates, as well as CR/CRh, as seen in the AZA-VEN arm compared to induction chemotherapy. Importantly, looking at the primary endpoint, you can see median EFS depicted in the left-hand graph, with median EFS for aza-ven being 14.6 months versus 6.5 months for those patients receiving intensive chemotherapy, and the overall survival curve to the right, not statistically different. You can also appreciate that some of the patient-reported outcomes are better for those patients receiving aza-ven, particularly with regard to the FACT-T, the depression syndrome symptoms, as well as symptom burden. Ultimately, this abstract concluded that the study met its primary endpoint, showing that aza-ven improves EFS versus conventional intensive chemotherapy with higher rates of OR and CCR when compared to intensive chemotherapy. A greater proportion of patients receiving aza-ven were able to go to transplant, and aza-ven was associated with less mortality, and importantly showed that aza-ven can be used in functionally fit patients with intermediate or adverse risk headed to transplant. There were some remaining questions that still, I think, plague us with regard to, we want to see more data with regard to MRD, we want to see outcomes for these patients in the post-transplant setting, and there are additional questions that I think we can address together in the panel discussion.
Thanks so much. That was a great presentation. I think that really succinctly summarized the high points of this plenary abstract. I think there were some questions, and I just wanted to start off maybe the questions by saying, the patient population, I think, was something that we were struggling with a little bit, as you talked about when you talked about the eligibility. There's a lot of, we know AML is a very heterogeneous disease. There's a lot of subsets of patients, molecular, et cetera, in this group. And I know they didn't control for that, but there was some discussion among myself and my colleagues that the majority of these patients, in addition to being fit and going to transplant, the majority of them were adverse risk, and there didn't seem to be that many intermediate risk. I think there was like 12 or 13 or something less than 15 in each of the categories. And so I know the conclusion slide says intermediate and adverse risk, and I see that you kind of have the intermediate or adverse risk kind of in parentheses. There also was some discussion that there was some differences in sort of the molecular subsets between the groups. They weren't controlled for that, but there did seem to be more like NPM1, IDH1, IDH2, and the aza-ven, which was favorable, maybe more P53s in the induction chemotherapy, and not that many intermediate. So what are your thoughts? Do you think that this is really underpowered for us to really make any conclusions, or can we say anything about intermediate risk or some of these subsets? What are your thoughts on that?
Yeah, thank you for that question. I think, when we look at the intermediate risk, that patient population as a total was 26 patients out of the total of 172 patients. So it's still a pretty small number and is not powered, I think, to say much about the intermediate risk, although we can use the data for that population to say it may, and we don't have subset analysis of just the intermediate risk to see, is the EFS better? It's not powered to answer that question in that way. But, I think there are some promising data that we get and glean from the paradigm study. Patients did better. There was less mortality. It did as a whole. When we look in a conglomerate of this patient population, patients are able to tolerate this therapy, and more of the patients that were getting to transplant were those patients that received aza-ven-based therapy. So yes, there's going to be limitations to this study, and I think that's one of the things that we have to keep in mind as we use this data. But if we have a patient that is young and we're wanting to get them to transplant, this may be a reasonable consideration for that patient, particularly if they have adverse risk and we have a transplant set and ready for them. I think there are questions with regard to MRD and how these patients will do in the post-transplant setting, and we're eager to see that data unfold. We'll get to that data. It just hasn't been presented yet.
Okay, so I don't know if Dr. Daver's on, but I guess the question that came up in the field here is, does paradigm signal the end of chemotherapy in adverse risk? So should we not be giving any 7 and 3 in young fit patients with adverse risk? And then for Dr. Daver, I know that your center has piloted a number of these intensive chemotherapy regimens. This was 7 and 3 alone, certainly not including any purine analogs like cladribine or fludarabine. But your center has been piloting, sort of incorporating ven and intensive chemotherapy for adverse risk. So would you think this is the end of chemo for intensive chemo for adverse risk, or do you think there's possibility that then an intensive chemo? What are your thoughts on that? And these were some of the things that was brought up on that last slide.
Yeah, I think that's a great point. So first of all, no, I don't think this is the end of intensive chemo in general, or for those who have the adverse risk features. I mean, adverse risk itself is a very, very big group population. So you have patients with secondary mutations, EAZH, RUNX1, ASXL1. And I think both with intensive chemo and, as you said, from our data sets now with clear flag ida-ven, close to 200 patients, we've looked at these patients with these subsets, and they actually can do quite well. Now, if we say the really adverse that I think we all believe, the TP53, the version 3Q, complex cytogenetics 5-7, I do think that there's a good argument there to say HMA ven and maybe even HMA alone for TP53 could be reasonable. For those patients, I think that's reasonable. But for the other, let's say, softer adverse risk, I'm not sure that HMA ven is going to be kind of the final answer. And this is the struggle we have. The data with our intensive chemo ven, even in something like KMT2A, is looking very, very good. The British have data of intensive chemo GO. So I'm not yet comfortable giving those a 40-year-old with KMT2A rearrangement frontline aza-ven. I think I would probably still go with flag ida-ven today with the transplant. But I think this is a good start, the paradigm, but we need much more data in those below 60, 65 to make this kind of a big shift in treatment, in my opinion.
Okay. So you guys think this is intriguing, and this offers the possibility that some adverse risk and some other patients newly diagnosed fit going to transplant with all those caveats could be given ven-aza, but you don't think that this is necessarily the end of intensive chemo and we need to get more information moving forward.
Yeah.